Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice example of lobular carcinoma in situ. This is a case of a 44-year-old female patient. She's actually the same patient as in the previous tip. But apart from the breast lesion, which was clearly sectioned, represented in the sclerosing adenosis, the ductal carcinoma in situ, and the invasive carcinoma that I shared with you in the previous tip, this was from the adjacent, what appeared to be the adjacent normal breast. And on this low power, power magnification, almost intermediate power magnification, this is one example of almost normal terminal duct lobular unit. And as you can see, we have here the ducts, the terminal ducts, and we have here the acini. Both are lined by a single layer of epithelium and a single layer of myoepithelium. Now keep this in mind, because in other areas, if you look into the outer contour, the appearance, the overall appearance and the contour, the outlines of the ducts and the acini is the same. But what has happened here is that the lumen are expanded by so many cells. It's really cellular. It's becoming busy, although the outline of the structure itself is maintained. And from this power magnification, there isn't much in the way of pleomorphism, another important clue. Now, if we zoom in a little bit, this is the outer layer. These are some of the myoepithelial layer, cells that are stretched on the outer side of the duct, terminal duct, or the acini. And the cells in between here are the cells of the lobular carcinoma in situ, little pleomorphism, no mitosis in general, and no calcifications. One important slight tip that might help you to think of the diagnosis, although the lumen are completely expanded, and this is the term that they use in the WHO, for example, the lumen are expanded by this proliferation of cells, the cell membranes are not clear. Extremely important small tip that might help to suggest the diagnosis of lobular carcinoma in situ. Another small tip, as if this is a signet cell, a signet cell appearance of the tumor cells. Remember that sometimes lobular carcinoma cells, whether invasive or in situ, can show this signet ring morphology. Again, a small hint to the diagnosis. Going back again now into the intermediate power magnification, I hope now you can appreciate the normal appearance of the normal outline of the terminal duct lobular unit, but with expansion. Now remember, in order to call it lobular carcinoma in situ, we have to have acini that are expanded, involving more than 50%. Half of the structure that we see has to be involved, expanded by the lobular carcinoma in situ cell proliferation. Now, in order to confirm the diagnosis, we have to do some stains, and one of the most important stains is E-cadherin. Remember that E-cadherin normally shows a membranous staining in the epithelial and the myoepithelial cells. This is a normal terminal duct lobular unit, whereas the one that is involved by the lobular in situ, expanded by the lobular in situ, I can see that the myoepithelial cells at the boundary of the acinus or of the terminal duct maintain this membranous stain, whereas the expansion of the center by the lobular carcinoma in situ cells shows loss of the stain. So the signature of E-cadherin is loss of the stain, the membranous stain in between the tumor cells in lobular carcinoma, in this example in lobular carcinoma in situ. This is another example or another focus where we can easily see some membranous staining of the expanded or the stretched out myoepithelial cells, whereas the lobular cells here, the lobular in situ cells, show complete loss. There are no lines in between. complete loss of the staining. Now, another more recently described stain is beta-catenin, following the same concept in normal ducts or lobules in the breast. We see membranous staining in the of the normal structures, whereas this staining, membranous staining, is completely lost in the lobular carcinoma in-situ component. So both E-cadherin and beta-catenin show essentially the same features. This is another ancillary stain that might help to establish the diagnosis. Now, sometimes the lobular carcinoma in-situ, where it starts in the terminal duct lobular units, sometimes it might extend through pagetoid spread into adjacent ducts. And again, the overall architecture is preserved, but what we see is sandwiching, and I like to use this word, sandwiching of the lobular carcinoma in-situ cells between the normal epithelial cells on the surface here and the stretched out myoepithelial cells in the outer part of the outer aspect of the duct. Again, this is on higher power magnification, one of the ducts that is involved by the pagetoid spread of the lobular carcinoma in-situ cells from the terminal duct lobular units into the adjacent ducts, and we can see easily, beautifully, the sandwiching of the lobular carcinoma in-situ component between the epithelium and the stretched out myoepithelial cells. Applying the same stains, E-cadherin will show loss of the membranous staining of E-cadherin between the groups of the tumor cells, whereas the ones with the maintained staining are the ones, the normal remaining ductal or myoepithelial cells. And exactly the same is shown with beta-catenin. This is the normal membranous staining of the myoepithelial cells, and the expansion in between is caused by the pagetoid spread of the lobular carcinoma in-situ cells into the normal structure. So the final diagnosis in this part of the case is actually lobular carcinoma in-situ. Remember that lobular carcinoma in-situ by definition has to involve the terminal duct lobular unit, in which more than 50% of the acini are involved, expanded by proliferation of those discohesive cells that show little pleomorphism. The clue comes from maintaining the architecture of the terminal duct lobular unit, but with expansion, as I shared with you. Remember that in some cases, pagetoid spread into adjacent duct can be seen. Remember that E-cadherin and beta-catenin can show exactly similar supportive immunohistochemical pattern, in which there is loss of the membranous staining both for E-cadherin and beta-catenin, whereas the beta-catenin and the E-cadherin maintain the stain in the epithelial and the myoepithelial cell layers. Remember that lobular carcinoma in-situ is important to recognize and diagnose because it carries a risk for the development of invasive ductal carcinoma and lobular carcinoma in both breasts, the ipsilateral breast, in which the tumor was described in which the lobular carcinoma in-situ was described in, and in the contralateral breast. And this is why it's important to recognize patients are usually kept on hormonal treatment, on tamoxifen, in order to reduce the chances for development of invasive breast carcinoma. I hope you find this tip useful in your daily practice. Thank you.